afternoon, everyone, and thank you for joining us for this webinar series at Pearly Health Center of Excellence. My name is Danny Sinden, and I'm the Director of the Pearly Health Center of Excellence in Frailty-Informed Care. Just to tell you a little bit about Pearly Health is a unique and innovative campus of care, home to more than 600 seniors and veterans living in independent apartments or receiving long-term care. Pearly Health is also a center for research, education, and clinical and therapeutic services. The Pearly Health Center of Excellence leads and participates in innovative initiatives, research, and knowledge translation activities that help advance quality of care for older adults living with frailty. Before I introduce our speaker for today, I want to let people know that there will be time at the end of the presentation for questions, and you can do so by writing them in the Q&A box at the bottom of your screen. And you can feel free to enter your question at any point throughout the presentation. We will answer the questions after the presentation is finished. Please also know that today's webinar will be recorded. You will be able to access this recording as well as past webinars on the Center of Excellence webpage. Once the recording is available, we will share the link with all attendees so that you can revisit the webinar anytime. We also ask that you take a minute or two at the end of the presentation to complete the short survey that will appear on your screen when you exit the webinar. We are fortunate today to host Dr. Kayne Park for our webinar. Kayne is a postdoctoral fellow in the Faculty of Health Sciences at the University of Ottawa, exploring the effects of age on human behavior. He earned his PhD in neuroscience at Queen's University by investigating the use of robotic devices as tools to assess neurological impairments. His current research is exploring whether robotic technologies can train older adults to improve their engagement in physical activity. In his spare time, Kayne is an avid foodie and enjoys finding tasty food to try in Ottawa. Without further ado, please welcome Kayne Park.
Thanks, Danny, for the kind introduction. So I'll just jump right into it. My name is Kayne, and as Danny mentioned, I'm a postdoc at U Ottawa, and I'm incredibly fortunate to be collaborating with Pearly for my postdoctoral work, as their goals to improve older adult care using applied research aligns well with my research goals. I just wanted to thank the webinar team as well for organizing this opportunity and actually giving me a platform to share my research. It's quite novel work, and I think it can provide a fresh perspective for improving clinical care. So for today, I'll be presenting kind of higher level concepts in motor control research, so a bit of the neuroscience field, with a focus on understanding how we move and interact with our environment. Then I'll be describing the importance of studying human behavior and the need for specified tools to assess this. And finally, I'll be highlighting how robotic devices can fill this role to potentially aid in clinical practice and ultimately improve clinical care. So our body and brain allow us to perform a plethora of different behaviors to achieve our desired goals. So the human body can perform relatively simple actions like reaching. So imagine yourself at a dinner table looking for some food to eat. You look around and see some pretty tasty green beans, looking particularly appetizing, so you simply just reach out to grab it. Similarly, when you're working on a puzzle, you look around for the next puzzle piece that will fit into the next section of the puzzle you're working on and just pick it up. So these slower actions require us to see our targets and know our body position before we reach them, and then actually achieve our desired goals. And it's not really a stretch to say that someone who can do these slower actions can do more complex tasks like serving a tennis ball. To do this, you need to use one of your arms to throw a tennis ball in the air, to see how high it was thrown up, and then use your other arm to swing the tennis ball precisely with the correct speed and power to hit the ball over the net. And so this is a much more complex task because it requires both arms to do different actions and the actual ability to predict the trajectory of where the ball is going to go. And so how we move depends on what our sensory system receives. As humans, we're highly reliant on our vision. Our eyes allow us to receive a wealth of information about the environment we want to interact with. So our eyes transmit information to our brain, like the size, the shape, the distance of an object, so that we can actually decide whether to pick something up, eat it, or just completely avoid it. And so going back to the green bean bowls, the bowl of green beans as an example, Let's again imagine you're sitting at the dinner table looking to see what kind of food you want on your plate. And so you see the bowl of green beans, looks pretty good, but you see that's too far for you to reach. And so you look around for someone around you and you ask them to pass the bowl to you. Your eyes would track the movement of the bowl. When you see that it's actually within reach, you'd start moving your arms to reach out, grab it, and then you'd eventually serve yourself. And so during this entire scenario, your eyes have been scanning all around you, transmitting information like the distance of the bowl from you, the contents of the bowl, and the different people around you, and the list goes on. And so our ability to interact is also reliant on our proprioception. So if you're not familiar with the term, proprioception is the awareness of the position of our bodies in space. So our brain's constantly receiving this information from the skin, the muscles, and the joints of our body. This information gives our brain an idea of where our body is in space without needing vision or any other sensory modality. And a simple way to test proprioception for yourself is to close your eyes. If you can kind of do this at home, just close your eyes and try clapping your hands. So most people should be able to do this. Um, you can do this with your eyes closed because your brain's constantly receiving this proprioceptive information from your limbs, which is then used to turn on specific muscles with an appropriate amount of force to achieve our goal, which is in this case to clap. And so if we go back to the green bean bowl example, when we want to move our hands to reach for the bowl, our brain uses the constant proprioceptive information from our arms to understand how much force we should exert based on where they are right now. Then the brain sends a signal to turn on the appropriate muscles to actually reach out. So while our arms are moving, our hands are opening up to receive the bowl. When we eventually touch the bowl, our hands feel the texture and weight of the bowl, which will send new proprioceptive information to our brains to let us know we're actually holding the bowl. And so proprioception is an incredibly important sensory system that, in my opinion, doesn't receive enough attention, despite being the key reason we can move the way we do. And so to really highlight this, I'm going to be showing you all a video demonstrating how impaired proprioception can drastically impact our behavior. And just a heads up in the video, sorry for this cursor, just heads up in the video, you'll see someone getting a needle injected into the thumb if you're a little bit squeamish. I'll try and give you a warning before this happens. So in the video, what you're going to see is a person's going to light a match for the start of the first half of the video, but then in the second half of the video, they're going to be injected with some anesthesia in their thumb, and it's going to have them lose proprioceptive feedback from their thumb, and then they'll again try to light a match. So here's the video. So this is them performing the task, which is just lighting a match with their fingers. Um, People could do this pretty easily, I would say. So they're very quick, light the match, it's all done. And so now they're going to get an anesthesia injected into their thumb. So the needle is going to be coming up here. And so this is going to numb the area and their brain won't receive any proprioceptive information from this area. They'll be getting it from their fingers, but not their thumbs. So now they're going to perform the task again with the numbed thumb. And as you can see, they're obviously having a lot of difficulties. And you should also note that they actually have to use the middle finger to help them because they don't have enough skill with their thumb and their index finger. So there we go. They finally eventually got it, but it was a lot more difficult with the loss of proprioception. And I also want to note that even though this person has difficulties, they're still able to see their movements. So you'd think that perhaps the vision might help them, but in this case, it's not because proprioception is so integral to how we move. So one of the reasons that the vision couldn't help them light the match is because of the inherent delays in our nervous system. So here I'm just showing the brain, eyes, arms, and different arrows pointing to specific areas of the brain. And these are neural pathways conducting information through our brains that process them and then get sent down back to our arms to actually move. And so the first the pathways I'll highlight are the pathways for visual information to motor output. So this goes from the eyes to the back of the brain in primary visual cortex, up to the brain in parietal areas, and then eventually to primary motor cortex. And this is the primary motor cortex is where movement gets generated essentially. And this gets transmitted to the spinal cord and then eventually to our arms. So this is a very simplified pathway of how visual information can be used by the brain to make movement. And the thing I want to highlight the most is that this extremely complicated circuit, at the end of the day, is lets you generate movements in about 90 milliseconds from when you see something. So this is extremely fast. But also want to note that this 90 milliseconds means that the electrical activity in your muscle is beginning. So to actually see movement, it takes about 50 milliseconds longer because you have to transmit the electrical information to chemical and then the arm actually moves. And so another pathway I want to highlight is the proprioceptive pathway. So this one goes from your arms, you get proprioceptive information from your arms to the spinal cord, to our primary sensory area, and then again to our motor cortex, so we can actually generate movement. And this can happen even faster. So about 60 milliseconds, your brain can process proprioceptive information. And just to put these like timescales into a bit of perspective, the time it takes to blink is actually about 300 milliseconds. So much longer, it takes much longer to blink than for your brain to process this very interesting, complex information and actually generate movement. And so these extremely fast processes are happening in your brain all the time, but you don't really need to think about how you move. Your body just moves when you need to. And so I want you to think about reaching for a cup or some type of object near you right now. Maybe you have a snack or something because it's lunchtime. Um, think about it, or even better yet, just try and actually reach for it. You can just grab it without really thinking about how to move. Your eyes move and your arms move, but you don't think about actually turning on each of the muscles. You're very familiar with kind of reaching to things, and so you don't have to think about activating these muscles. You choose your goal and your body just follows. And so this is actually quite complicated because your eye has about 6 different muscles controlling it, and your arms and hands have about 60 muscles. So these muscles need to be carefully coordinated and activated to move as smoothly as we do. So when your goal is to reach for a cup, you don't think about turning on and off each of these muscles in your eyes, hands, and arms with the correct amount of force and timing. You just kind of look at the cup, think, I'm going to reach for it, and your brain sends the signals down to your arms to accomplish the goal. So these concepts in neuroscience research might be quite interesting, but why are they important for us to know? So for scientists like myself, we want to understand the relationship between the body and the brain. And so we can be able to explain and predict how people actually move. For example, when you drive to work sometimes, you just kind of end up there. You don't actually remember getting to work. The process became so automatic that you didn't need to be aware of the roads you took or what the traffic was like. But you definitely paid attention to it and you got to work safely. It's not like your brain completely shut off during this. And so your body was sending sensory information from brain to your brain to drive the car through traffic and follow the rules of the road. But you don't remember things like, oh, how many cars were there on the road or what color were the cars around you? You just got to work safely, but you don't remember this. So our brains control how we move, interact, and think. So it's quite fundamental for us to understand how it works to learn who we are. And so it's incredibly important to understand human behavior for clinical care. So stroke is a neurological disorder caused by a blockage or rupture in blood vessels of the brain, leading to brain damage. After someone has a stroke, they could have neurological damage causing a diverse range of impairments to typically one side of the body. And so we have tools like MRI and CT scanners, which are advanced imaging tools that allow us a non-invasive way to see the extent of structural damage to the brain. Even though we not know a lot about how the brain works, the many different regions of the brain and the numerous connections between these regions make it impossible to accurately predict the resulting neurological impairments. And so if someone has a stroke resulting in damage to the left side of the brain, clinicians will generally expect impairments to the right side of their body. But the question is, to what extent? Is it affecting the entire right side of their body? Is it a severe impairment? Is it mild? Stroke is commonly characterized by impairment to one side of the body, but are we really sure it's only one side of the body? And so we need to be able to accurately assess human behavior to properly diagnose these kinds of impairments. And just I'll be focusing on stroke throughout the presentation, but a lot of this work can be quite relevant to other disorders affecting behavior, like Parkinson's disease or traumatic brain injury. And so different methods have been used to assess human behavior. A widely used approach is just visual inspection. This means to simply look at someone and use a scoring tool to help quantify what's seen. And so this method is low cost, readily available, easy to use, and we can get a general measure of human behavior from it. A common clinical tool, sorry about the laser pointer, a common clinical tool used to measure impairments for people with stroke is the Shidoko Master Stroke Assessment, the CMSA, which I'll refer to as. And so the CMSA tests whether participants can complete various arm movements. And so the healthcare practitioner administering the assessment will judge whether participants can complete specific movements listed on the assessment. More complex movements will result in a higher score, and these scores range from 1 to 7, with someone scoring a 7, meaning that they perform what's normally, they perform like a normal human. And so each score has 3 movements that participants need to perform, and they have to do at least 2 of the 3 movements to achieve that respective score. So example of one of the movements for scoring a 7 would be to scissor your arms in front of you 3 times within 5 seconds. Looks something like this. And so like I mentioned before, using visual inspection to assess impairment has clear benefits, like being low cost and easy to administer, but there are some limitations with this method. And so the first is that visual inspection can be subjective. One healthcare practitioner's assessment could differ from another's, or even their own assessment could vary from day to day. And I mentioned with the CMSA, participants are scored from 1 to 7, with 7 being normal. The question is, what does it mean to be normal? Can you actually see what normal is? And so in this figure here, this person is reaching for a cup which has been labeled normal. So on the next part of this figure, this person with a stroke is reaching for a cup with their affected side. So this is the side that is expected to have impairments. And so they have difficulties reaching for the cup with their affected arm due to the stroke and are now making what are called compensatory movements to help them. So this means that the participant will use other parts of the body not typically used to help them achieve their goal. In this diagram, the person with stroke is reaching for a cup and has difficulties lifting their arm. And so their goal is to pick up the cup, so they'll make any necessary movements to adjust to do this. In this example, they lift and rotate their shoulder forward, they tilt their torso to shorten the distance between their hand and the cup, which makes it easier to reach and execute their goal. And so here the shoulder and the torso are compensating for their impaired arm. And so since they successfully completed their task, but since they use compensatory movements, a clinician could view this as an impairment. But what if these compensatory movements were subtle and difficult to actually see if there was compensation or not? They could be assessed as performing normally, similar to someone who didn't make compensatory movements. Another limitation with visual inspection tools are the coarse scales used in scoring systems. So after identifying impairments, professionals will need to record how well a patient performed. So looking at the CMSA, it relies on coarse scales to grade human movement. Clinical tools with coarse scales make it easy to judge how impaired a person could be because they fit into nice specific categories. And these scores also mean that the test is reliable because it's easy to say this is a 6 on one day and this is a 6 on another day. So a reliable test is a good measure of a good test. But ultimately, the actual categories they fit in provide very limited description. And so let's take this for example. If you score a 6 on the CMSA, it says their movements are near normal. And so what does near normal provide for a healthcare practitioner who needs to develop a customized rehabilitation protocol for the patient? And to put this into a perspective, if you think about school systems and the letter grade scoring, so F means fail, D, C, B is average, A is the best mark. If someone gets an A on a test, uh, we know that they did well, but how well did they actually do? Do they just score just a bit above a B? Do they get absolutely perfect on everything? So we need a finer scale to understand performance like they would use in percentages. So instead of saying someone got an A, maybe someone got a 92, which we know is like quite a good performance. And then we can actually look at their scores, an actual test to see how well they did. And so another limitation with this approach is that it's difficult to actually track changes. So let's look at another example. If someone had a severe stroke and they couldn't lift their arm, they would be graded a 1 on the CMSA because they couldn't make any of the specified movements. On the next assessment, the person could lift their arm, showing improvement, but they still can perform any of the listed movements. They still get a score of 1. So in this example, this person's definitely improved, but the practitioner can't give them a higher score on the CMSA because they didn't do any of the required movements of that level. So would they change rehabilitation strategies or continue with the same protocol? And so now the examples I gave are very simplified scenarios and a very complex approach towards diagnosing disorders, but it does highlight that we need objective and accurate tools that can provide a better characterization of disease. And so we've made unbelievable technological advances for the past few decades. If you look at our phones, our cars, our computers, like we obviously have the technology. We just need to develop appropriate technologies that can be successfully translated into clinical settings. And so starting kind of low on the computerized scale, these simple devices like stopwatches are a computerized tool, and they can help us measure things like walking ability. And so a commonly used test is the 6-minute walking test. Participants are given 6 minutes to walk back and forth in a hallway, and we get a measure of their walking ability by the distance they make in the 6 minutes. And so we can start and stop a stopwatch to get time in seconds and milliseconds, which is much more accurate than a coarse scale ranging from 1 to 7. A stopwatch is easy to use and it's quite accurate computerized tool, but it's still not very powerful for assessing human behavior. Do you remember if I mentioned before that our visual system, the input is delayed by 90 milliseconds? And so also this tool relies on a human to actually press buttons, which will also take a substantial amount of time, maybe like 200 or 300 milliseconds. And so even though this tool can be accurate, it is subjective because it relies on human input. This tool is also inappropriate for assessing very rapid actions like reaching for an object, which can be done in under a second. And so kind of moving on to the other end of the technological spectrum is our motion capture systems. So these systems are very powerful tools that can objectively and accurately assess measures of human motion. These systems use an array of cameras positioned to record human movement from many angles. Participants have markers placed on key body parts, which are picked up by the cameras. The location and movement of these markers are then used to develop 3D models of the participant's body, which can be used to analyze the motion. And so the tracking computer is computerized, so it's an objective measure. It's also a very accurate system because it uses numerous cameras at different angles and samples data at a minimum of 120 hertz, which means every second they're getting 120 new data points. So it's pretty accurate. And these systems have been used to study how humans walk and understanding whole body motion for both healthy and clinical populations. But even though motion capture systems are obviously a very powerful tool for understanding human motion, the current systems aren't built to understand how we interact with our world. So previously, I talked about the importance of sensory information to guide how we move. Our brain needs to be able to quickly process this information to make appropriate actions. So if our ability to process this information is delayed, we might do something minor like drop a bowl or something serious like get into a car accident. And so motion capture systems can help quantify motion, but current systems don't allow us controlled ways of knowing how someone would respond to new or sudden sensory information. We need an actually interactive tool that can measure human behavior to assess our ability to move and interact with our environment. And so that's where the KinArm comes in. So at the Faculty of Health Science building at the U of Ottawa, we have the KinArm robotic device, which is actually just developed over in Kingston, Ontario. So a very proudly Canadian-made device. The KinArm is an augmented reality system where here we go. Participants hold on to these handles here, and they see where their hand moves on this horizontal screen that's placed right above the hands. And so the robot allows us to make computer-generated environments, which are essentially video games that people can interact with. The motors are also able to push participants' hands so that we can test participants' proprioception. And so the system allows us to objectively assess data because participants' performance are measured solely by the robot. And the robot also captures very accurate data as well. The KinArm samples data at 1,000 hertz, so every second records information like the position, speed, acceleration 1,000 times. And the robot we have at UAuto also lets us track eye movements, so we can investigate eye movements. And our balance, we can also assess balance with this system when people are standing in it. And so a Kayne arm is a single system which can assess many different ways we move and interact with our environment. And so here's just a video showing the Kayne arm. You can see the handles here. And again, any movements you make with the Kayne arm, you can see it on the screen. And here, the blue path is just showing where the hand moves. And we also have tasks with the Kayne arm. So there's already pre-built tasks in there that access different functions. So this one's called object hit. The goal of this task is to use both arms to hit these like red balls that come towards you. It tests bimanual coordination, rapid decision making. It's actually quite entertaining task to be fair. And as the task progresses, it'll speed up. So you're really testing those rapid decision making skills. And the next task I'm showing is called the ball on bar task. So participants' hands, between them, there's a bar, and on top of that bar, there's a ball. And so what they need to do is put the ball into those red dots by moving both their hands and also keeping the ball on the bar. And so those are a couple of tasks already built on the Kayne arm, but I'll describe a few more. So one of the tasks that's been developed on the Kayne arm is called the visually guided reaching task. It's called VGR, I'll call it. So here participants are shown a red target and they just simply have to move towards it. There'll be 4 different places the target can appear, actually 5 including the center, and participants' hands are located with this white cursor. So they just have to move the white cursor into the dots, the red dots. As well, I'm showing the hand here, but the hand's not actually shown to participants. We actually block off any vision from their hand. And so they just see the white cursor and the red dot. And so I've been talking about reaching a lot during this presentation, and it's for good reason. Reaching is a basis for many different things we move, many different movements we make. Something like grabbing something from a bowl or grabbing our toothbrush. It's a very generalizable action that we need to do for most things in our life. And so it's very important for us to understand this ability. So with a task like this, we have many different parameters or measures, we call them parameters, to assess movement. And I'll highlight just a few. The first one is reaction time. So if we look at reaction time for someone who does the VGR task, we can assess how quickly someone's brain can process sensory information. We can look at hand speed. So we can see if your brain can activate enough muscle fibers to make quick movements. Or we can look at endpoint distance, which is just a measure of accuracy. We can check if someone can have good control of their upper limb so they can actually place their cursor into the target. And so reaching might be simple for most people, but it can be incredibly difficult for someone following a stroke. So one way we've used the VGR task is to understand a neurological disorder called visual spatial neglect. So this is a neurological disorder after stroke, commonly characterized by an inability to see one half of the world. The severity of neglect is commonly tested using pen and paper examinations, what I'm showing you on the screen. So someone with stroke could be asked, just draw a clock from memory. So they'll draw the numbers here, but obviously this looks like someone here has neglect because this side of the space, they don't draw anything. Their numbers are actually kind of skewed towards the right, so they don't have a perception of anything on the left side of their space. Similarly, they're asked to draw just this diagram here with like the 2 trees, the house, and the 2 trees on the right. And this person only drew the 2 trees on the right, so they just couldn't see this side of the world. So similar to other clinical tests, these pen and paper tests are subjective. You need someone scoring it based on what they see. So it's also important to note that these tests are static measures. So nothing's moving, everything's still, and patients only need to draw a picture without any real time constraints. These static tests aren't reflective of the dynamic world we live in. Even walking down a hall and turning a corner, you need to be able to quickly process new information coming in. Like, is someone down that corner? Is that a corner I don't want to walk to? So the world is quite dynamic. And so these pen and paper tests can't really capture that. And so we used an 8-target version. The video I showed before was a 4-target version of the VGR task to get a better picture of potential impairments for someone with stroke. And so I'm not going to go into full explanation on the study, I'll just go to the brief highlights. So we assessed 265 participants with stroke and found many different interesting features of neglect-related impairments because we use this robotic task. The first was that we found about 30% of people with stroke, regardless of whether or not they had neglect, were impaired in reaching to the left side of space. And so some people had impairments reaching to these top two targets on the top left, and some people actually just were impaired in reaching for any of them. And the most interesting thing that we found for this task was that these impairments didn't mean that people couldn't reach. On some trials, they could reach to the left, or the reaching was delayed, or they just couldn't reach at all. So it was quite varied even within a single person. So let me kind of highlight this further. So here I'm showing a figure with movements towards the right. So this person made reaching movements towards the right. And this graph here shows each reach. So each of these lines are one single reach to the target on the right. And there's about 8 of them. And so you can see that for the movements to the target on the right, besides this reach here, and even including it, actually, they're quite well aligned. So it means they're quite consistent across trials for reaching to the right. So they looked really relatively okay. But now if we look how they reach to the left, you can see that there's a lot of variability in the reaches. So again, each of these lines are single reach for a trial to the target on the left. And you can see that these first couple of trials, they actually performed like similar to what they did on the right, but you see these other trials where they started much later in reaching. And sometimes you see these little squiggles at the bottom, they just didn't reach at all. They couldn't see something there. So they had a lot of variability in the reaching. And we can only really see this with a robotic tool because we have time to consider, and something we can't see this in something like a static tool because they just have unlimited time. And so another task that's been developed on the Kayne arm is the reverse visually guided reaching task, where we assess cognitive function. So the idea behind this task is that we as humans are able to control our bodies to do complex tasks to attain our goals. And so when you're playing something like table tennis, the ball's coming towards you, you kind of automatically want to hit the ball so that you can return it. Um, but the goal is to gain a point, it's not to hit the ball. So what if the ball is going out of bounds? You'd actually want to inhibit this automatic response of hitting the ball and just stop your arm from intercepting it to let the ball go off the table. And so again, our goal is get a point, not hit the ball. So this type of action requires us to use our cognitive function to inhibit our automatic response. We can have participants perform a similar task on the robot. And so this is the reverse visually guided reaching task. So in this one, the participants' hand movements are actually misaligned. They go in the opposite direction of the white cursor. And we want them to get the white cursor into the red target, not put their hand into the target. So it's actually quite difficult to do a task like this because you automatically want to put your hand into the red target, but that's not the goal. The goal is to get the white cursor in the target. So you have to move in the opposite direction. So a task like this can help us understand cognitive function. Here, again, I'm showing the schematic of the visual and proprioceptive neural pathways to the brain. And now I'm adding these orange arrows over here to the prefrontal cortex, which is involved in cognitive function. And these actions take about the longest, they take about 150 milliseconds. I also want to note that the path is quite distinct from the others, meaning that damage specifically to the prefrontal cortex could impair just cognitive function. And so between the VGR task and the RVGR task, we can compare cognitive function because the goals of the task are quite similar. The only difference is this added cognitive element. And so the next task I'll be showing is the arm position matching task, which tests proprioception. So participants' passive arm is going to be moved by the robot, and their active arm is going to move. They're going to move this arm so that it's kind of mirror matched on the other side. So I'll play the video just so you can see it a little bit. So the passive arm again is moved by the robot, and the active arm, the participant is trying to match the same kind of side. So you can kind of see how that looks here. And again, they can't see their hands at all. In this case, they'll actually see nothing on the screen because the robot's only moving their arms, their passive arm. And so on the right, I'm showing you how, sorry about that. Sorry, I had an issue with this before. The video is a very long video, so let me just find it. Yeah, sorry about that. So I'll just skip the video again because you guys seen it. So here I'm just showing how a healthy participant would perform in this task. So the passive arm again is on the right here, and these icons represent where the robot moved their hand. And these icons on the left for the active arm is where the participant tried to mirror match the location with their active arm. So they move the hand with the active arm, and the robot moved the hand with the passive arm. And so you can kind of see that where the hand moved for the active arm is pretty aligned with where the hand would move for the passive arm. I'm showing this diagram here just to overlap the two so you can see it a bit better. So where the hand moved for this star icon, it's only a bit shifted for their active arm, but where this triangle is, they're very overlapped. Square is very overlapped, and so they did very well at matching their arm position. So this is again a healthy participant. So if we look at someone with stroke, you can see a much different picture. So again, these icons on the right or on the outside are the passive arm hand. So this is where the robot moved their hand. And so when they tried to match it with the active arm, they had a lot of difficulty. You can see the distance between the icons for the square, the star, they're all very centered towards the middle. So they really couldn't move their arm to match where their passive arm was moved. And just for the sake of time, I'll skip this next task. So I wanted to know, I keep saying impairment. So what does impairment actually mean? The World Health Organization defines impairment as any loss or abnormality of physical or psychological, physical or anatomical structure or function. And so just for the relevance of this presentation, I'm going to highlight the abnormality of function. What does it mean to have abnormality of function? To actually know what abnormality is, we need to know what normal is. So I've talked a bit about normal in this presentation, but I really didn't elaborate on much. Let's go back to someone performing this VGR task. And just on inspection, can you say this is normal? And so it looks okay, but what if this person was left-handed? We need to know certain demographic information that can affect our behavior before we can actually say someone is normal. So demographic information like age, sex, and handedness can all have effect on how we move. So a left-handed person doing this task with the right arm will likely perform differently than a right-handed person performing this task with their right arm. And so to determine normal behavior, we need to first collect data from a large amount of healthy participants, and then we can establish what a good range of normal performance would be. And so that's what the Kayne arm has at the moment. I've shown a few of these tasks already, but there's quite a few more. And we have a lot of controls for the tasks. So with the Kayne arm standard tasks, we can assess a range of different sensory motor or cognitive functions, and we have large data sets of healthy controls to say what is normal in these tasks. So that means a broad range of neurological functions can be tested in diverse patient groups, which are then backed up with this healthy data. And so we've used the Kayne arm to look at things like stroke. We've done a lot of work in stroke, TIA, which is essentially like a mini stroke, ALS, Parkinson's disease, epilepsy, and even kidney disease. And so more research groups are seeing the value of robotic tools as assessment devices because they can quantify subtle impairments in these diseases that really wouldn't be possible just by visual inspection. And so this work allows us to characterize disorders so we can learn more about how they affect neurological function, which can lead to improvements in clinical care. And so I've already mentioned an already established list of tasks, but we can develop new tasks on the Kayne arm to keep up with new research to push translational work forward. And so again, we have a good idea of the neural circuits involved in processing different sensory information. And I've mentioned some of these circuits already. They have similar brain regions, but they also have distinct ones. So this means that brain damage to one area can affect all function, but brain damage to another area could affect just one function. And so the task I showed earlier focused on assessing cognitive function with the RVGR task, visual motor skill with the VGR task, and proprioception with the arm position matching task. And so we can compare cognition and vision with the RVGR task and VGR task because they're a reaching task, and their goal is similar. But we can't really compare vision and cognition to proprioception with the arm position matching task because it's quite a different goal. You're looking at spatial targets for the reaching task, but for the arm position matching task, there's nothing really to look at and for you to achieve your goal. And so for my dissertation work, a big part of my work was to make a new task so that we can look at different sensory inputs and compare them to see if someone can have selective impairments in proprioception, vision, or cognitive function. And so the premise of this task is it's a lot like Pong. So your goal is to intercept this white ball moving towards you. The ball can move left or right, so you have to use your rapid visual input to adjust for this. The hand could actually be pushed by the robot. You can't really see it here, but the robot is actually pushing someone's hand left or right. And again, you have to use your proprioceptive feedback to respond to this. And we also tell them ahead of time that the ball can turn red. So here we're testing cognitive function because we're giving them a novel rule that they have to implement. So the novel rule is if it turns red, you avoid it. So instead of automatically just staying where you are, you want to get out of the way. And so just in brief, I'll give a big overview of the results. So the first is that reaction times for the different trial types were quite distinct. This was expected result because we know that proprioception should be processed faster than vision, which should be processed faster than cognition. So seeing this result for this task indicates that the task is assessing behavior the way that we think we want it. So next, we found that most people with stroke were impaired in this task using their affected arm. 85% of our cohort of stroke were impaired in their affected arm. And importantly, we saw that 60% of people were impaired using their unaffected arm. And so this is the arm that's not supposed to be impaired classically from what we know about stroke. Um, but this means that the neurological damage to one side of the brain doesn't necessarily mean that one side of the body is impaired. There could be impairments to both sides of the body, albeit the classically impaired arm will have more severe impairments than the unimpaired arm. Um, and the actual neural processing in the brain doesn't involve just one side of the brain. It actually involves both sides of the brain. So last, we're also able to find what we were looking for. Some people had impairments only for vision, but not for proprioception. So this task was actually able to isolate visual impairments, but not proprioceptive impairments. Sorry, they was able to isolate people with just visual impairments, which were fine with their proprioceptive input. And so I hope I've made it clear that our ability to move and interact with the world is an incredibly complex process. We need accurate tools to help us understand human behavior and reduce our reliance on subjective measures, providing us with biased judgments of neurological function. And finally, we have robotic tools that can assess behavior by providing objective and accurate measures of healthy performance and behavioral impairments. And continued work in this field can help us understand diseases and likely lead to improvements in clinical care. So I want to thank everyone for listening. I hope everything made sense. And I also want to do a little plug for a study I'm recruiting right now. It's an intervention study that Danny mentioned at the start of this presentation. It's about 12-ish weeks long, but you get to play with the robot and you can be compensated for up to $100 of your time. So if you're interested, please let me know and I'll leave it up for questions from here.
Thank you so much, Kayne. That was so interesting. We'll just wait to see if there's any questions. I don't see any yet. But just while we're waiting, I'm wondering if you can talk a little bit more about the application of the kin arm to other populations, such as people living with frailty.
Yeah, so we're actually starting to look at using the kin arm again for more diverse groups. particularly ones that haven't really used very objective or accurate measures to assess the impairments. And so frailty is, in my opinion, one of those populations. A lot of the tests that are used are, again, based on these clinical tests where you just kind of look at someone and say, oh, like maybe this person looks frail, but like, what does that actually mean? Like, humans are good at categorizing things, and you can say that, oh, someone looks like they're having frailty, but actually defining that is quite difficult because everyone's opinions could be different. And so having an objective measure like a robot can help you actually be more specific on what actually is frailty, what diagnoses would help you understand what frailty is. And then this research in potentially one hospital could be moved on to other hospitals. So it allows for a lot of collaboration. And so we're opening we'd like to do more work in other clinical populations like frailty. We're also doing work in children to look at neural development. So there's a lot of applications for understanding how we kind of move and interact with the world and using these objective, accurate tools so that we can understand disorders or development even better.
Okay, thank you. And in terms of the tasks of the kin arm, would those differ? Or maybe you could talk a little bit about some of the other tasks that are
Sure,
possible
yeah.
in the kin arm, and how would that maybe differ with different clinical populations?
Yeah, so one of the tasks that I actually skipped on was this one right here. I'll play it for you now. I mentioned the object hit task before, but this one's called object hit and avoid. So people are given two objects that they're supposed to hit and any other object they don't hit. And so here we're testing things like bimanual coordination again, like the object hit task. But here we're also looking at cognition because you're supposed to hit some objects, but not others. And so here we can test cognitive function. Um, it's a very important function, obviously, for a lot of what we do in our life. So understanding cognitive function with a task like this helps us see, can people make rapid decisions based on these shapes and a lot of information coming at you at once. We do some work in Parkinson's that I showed. A very interesting trait about Parkinson's is that people are actually hyper fixated on stuff. So with a task like object hit and avoid, someone with Parkinson's might just hit all of the objects because they are hyper fixated and they can't inhibit their response. So you'll actually see them moving very well because there's so many sensory cues that help them hit this task.
Okay, thank you. So we've got a couple of questions coming through here. The first one is, has the team studied the kin arm for learning disabilities, i.e. Tourette's?
Um, I'm not too sure. Again, we're starting doing work with kids in the robot. Neural development's a very interesting side of neuroscience that I'm not too familiar with. My past research has largely been on stroke, but it's very interesting to look at. Something like Tourette's, from like a high level view of my understanding of it is that they can't really inhibit some of their actions. So again, like I was mentioning with Parkinson's, someone with Tourette's trying to do the task might just have these rapid movements that they can't inhibit. Um, I don't know if it's very sensory driven in Tourette's. It's definitely something to look at. It's quite interesting. But yeah, the robot can give you an actual objective measure because yeah, I don't know for the screening of Tourette's what they do, but I can't imagine there's many accurate tools for it. So something like object hit and avoid task, for instance, could be a good measure for this lack of inhibition that that group could have.
Okay, thanks. The next question is, so you mentioned TIA. Can this be used for TGA or transglobal amnesia?
I can't answer that question. I'm not familiar with trans. Uh, I'm not sure what you said, the amnesia. Um, Amnesia makes me think it's some sort of memory disorder. We do have some tasks that look at memory function. Well, there's the list. I'll show you the list. I don't have any videos of it, unfortunately. So here we have a task called spatial span. It tests memory. So participants are given different squares and they kind of light up, kind of like maybe like a Simon Says. And so once initially one square lights up, they have to remember where that square lit up, and then it unlights, and then they move towards it, and then the next one will be, oh, maybe two squares light up in this grid, and then you have to move to those two squares, and then it'll keep going, and it relies on your memory. And so perhaps something like amnesia could be studied there. Maybe how fast people respond to these squares, how long it takes for them to actually remember which squares to go to. A very simple one would be just how far they can get in the task. So yeah, different functions are tested on the Kayne arm.
I don't see any other questions. I guess just more sort of broadly, and again, sort of back to the frailty, because that's your upcoming study and obviously something that the Center of Excellence is very interested in.
Mhm.
But how do you think robotic devices in general could help identifying or maybe like earlier identifying frailty in an older adult population? Maybe how could we apply that in clinical settings like long-term care or even older adults living in the community?
Yeah, so the again the benefit of the robot is that like it's an objective tool. And currently it's being used as an assessment tool. So for some of the research hospitals that do have a kin arm, they're using it to see if like they can assess actual disorders. But another function of it could be used for understanding the process of aging. So that's the project that I'll be working on next year. And so we're going to use the robot to see from the tasks that we have already, so we can compare their performance to healthy controls, if someone who's aging is impaired in a certain task or certain parameters of a task. And later on, we can check them later to see if they get worse or if they have some sort of disorder like frailty. Like, was that kind of function that we tested with the task able to identify those people versus someone we test on a task at the start and the follow-up, they were okay. So we can use it as like a form of like it's a diagnostic test at the end of the day. And so we can test that function. With respect to aging,
Yeah, okay. Thank you. I don't see any other questions. I'm wondering if just briefly before we wrap up, if you want to go back to the recruitment slide and
sure.
just maybe talk briefly about what people can expect if they were interested in participating, kind of walk them through what that would be.
Yeah, yeah. So it's quite an interesting study because we're using the robot as an intervention tool. So I've said the robot is used largely as a diagnostic tool, but now we're kind of moving it more into rehabilitation. And so in this study, we're seeing if we can improve engagement in physical activity for older adults. And so we'll check them before the intervention on measures of physical activity, like their walking ability, their daily step count, things like that. And then we'll have them play video games on the robot for a few weeks. And then once they're done with this, we'll assess them again, and we'll see if the robot was actually able to get them to be more physically engaged, physically active. And then 1 month later, we'll assess them again to see if any changes we saw between the first two assessments. They'll have lasting improvements in their physical activity levels. Yeah, and so you get to come play around with the robot, see the equipment that we have at U Ottawa, and we'll be promoting the kind of work that's being done to actually improve physical activity in older adults because we know that it's essentially a pandemic that if you have less physical activity generally, but more importantly, when you're aging, it leads to worse outcomes in quality of life.
Okay, thank you. So if anybody out there is interested, the contact information is here on the screen and feel free to share it as well with others who you think might be a good fit for that study. So I think that's it for questions. So I think we'll close it up now. So I just want to thank you, Kayne, so much. That was a really interesting presentation. A lot of work clearly has gone into this work over the last few years. So thank you so much for sharing. We look forward to hearing the application to frailty and the results from that. And maybe we can have you back again to present. And I just want to thank all of those people who attended today's webinar. We hope you enjoyed it. Please stay tuned for information on our upcoming webinar in May. And in the meantime, if you would like to learn more about the Center of Excellence, our current projects, or if you have ideas about upcoming webinars, please reach out and visit us at our website at pearlyhealth.ca/Center of Excellence. And just a reminder, we would really appreciate if you could complete the short survey when you exit the webinar. And that's it. Thanks again, Kayne, and have a great day,
Perfect.
everyone.
Thanks again. Bye bye.